morning, class. Today we're going to be talking about anthrax exposures. We're going to have a couple of visuals, so we'll see all of our different ways that our patients may be infected. We will know when and where anthrax originated from and how it's been used in today's world. We'll see the different types of way that a patient can get infected and the proper treatment that we should do. We know that anthrax was first reported in 1500 before Christ in Egypt, and ever since it has continued to become the social and economic damage ever since. So, anthrax actually comes from the Greek word that means cold, due to the fact that the lesion that it develops in a cutaneous infection, which the black necrosis. We will see that in further pictures. Anthrax is actually, it's a bacteria that forms spores. Those spores are the pulprits, when you say that, and they actually live in the soil. They can live in harsh conditions. They can live from decades up to centuries, and animals grazing the soil, they will eat the soil. They don't tend to have too many spores that they have to ingest, but they do become infected. And what happens is that those animals, if they do eat enough of those spores, they do die, and blood stops clotting in them. And so they start losing blood by orifices because of the clotting. They lose it in mouth, nose, and other openings, as we see in this poor little pig. Here we go, a little cycle of anthrax. Cows vegetate, they eat it, we kill them, we eat it, we become infected with gastrointestinal anthrax infection. So, also, insects do, flies, or as we call, mosquitoes. They can come also, and they can bite an animal that has anthrax, and if they actually bite them where they were infected, they come and bite us and suck blood, then we become infected. So then we'll start seeing some kind of necrosis. So that'll be scary. We just have to keep an eye out when there ever is a situation that occurs. There is 4 different ways that a human can become infected. Inhalation, which is one of the big ones that is more prominent into patients. Cutaneous, gastrointestinal, and our least common is our oropharyngeal. To be infected by inhalation anthrax, you can actually breathe the anthrax, the spores, but there has to be a certain number of spores, over 10,000 spores, to actually become infected and start seeing development of the anthrax. There's actually been stories that farmers that live out in the area, they have anthrax in their soil due to the fact that it's not in a large amounts. They don't become infected, or they don't start seeing symptoms per se. And due to that, they get a little bit of immunity to it, but they never start showing those symptoms to where they start having the respiratory distress or anything. Those anthrax spores actually become the larger spores, excuse me, get lodged in the throat, and they start having a problem there. The smaller ones germinate down to the trachea, into the alveoli, and that's when it starts penetrating, and it gives problems to the patients, and that's when we start seeing that respiratory distress. Excuse me. Okay. Signs and symptoms of the inhaled anthrax. We will see fever, we will see chills, cough, headache, respiratory distress, or that difficulty breathing, and chest discomfort. So those are couple signs and symptoms to just keep in mind whenever we are sent out to one of those calls. The pulmonary anthrax infections are associated with 90% of deaths, so if untreated. So it's good to have that treated as soon as possible. Cutaneous anthrax, which is our prime example of when we talk about anthrax, that's what we think about, which is our lesions. If a person is in contact with anthrax spores and they have a cut or they have any kind of wound on their hand or on their arm, and those spores become intact with that, we start seeing those developing bacteria, and we start seeing blisters. The blisters then actually have small, or like we say, prime example of that small black sucking hole that is actually necrotic, and due to the fact that it just kills those nerves, those nerve endings, and those patients don't feel any pain in those lesions. So actually, you would think that it does hurt, but it doesn't. Gastrointestinal, we have already mentioned, which is when we eat meat or anything that's been with the spores and we ingest it, we can start seeing ourselves infected. Now, when we see gastrointestinal, abdominal pain, just discomfort, we can also see fluid buildup, acidity in the stomach, and patient will start vomiting blood, having diarrhea in the blood. So we have to be careful with that because those patients will become shocky very quick. Hypovolemic shock, so keep in mind fluid bolus. Meningitis is one big thing that does come after anthrax due to that bacteria, because the bacteria is flowing in the blood. So the other one is oropharyngeal, which is our least common, as we said. And that one develops in the oropharyngeal, like I said. I mean, we start seeing the ulcers, the sore throat, swelling of the neck, just discomfort, dysphagia, and the patients actually, they don't want to swallow, they don't want to eat, they don't want to do anything, and they start having that respiratory distress also. So it's not too common, but it is seen. A proper treatment, proper decontamination. Always decon the patient. Don't become the victim. Make sure you have hazmat and they are there so they can decon. Have your proper suiting, BSI. Once they're at the hospital, they do get their antibiotics and they handle it from there. Make sure you call them, let them know that you have a patient that is probably contaminated with anthrax. And we know that Louis Pasteur was the first one who developed that anthrax vaccine in 1881. And studies show that so far they've actually worked on it and actually become better. And we know that 9/11 was the big outbreak that we have recently with anthrax, which was after 9/11, and the senators and all the about 5 people died about it, and there was 17 others infected. Full BSI, and continuing on, we see the level of proper hazmat suits that we have to have. Now we're going to do a little scenario. We're going to have Paul. Do you mind being my patient? We'll do a little scenario of a 30-year-old male that's worked for the CIA. He's actually worked for the CIA, and he's been receiving mail, and it's been about 5 years that he's just been receiving anonymous sender, and we're going to go ahead and be dispatched to a residence. And what do we do from here? So first of all, come up to the residence. Don't even get off the car because of the information that was dispatched to us. Keep in mind hazmat. So go ahead and call hazmat. We don't know what's going on in the residence. We don't know what's going on with the patient. So first, get hazmat on scene. First, decontaminate. Make sure that everything's seen and safe. Don't become a patient. Once we have our proper suit, once the patient has been decontaminated, taken the clothes off and everything, we can go ahead and proceed with proper treatment. Come up to the patient. We see the patient has respiratory distress, and also we see lesions just by coming up to the patient. I can hear him wheezing, just having that difficulty breathing, a little pale. So we already have first patient, possible anthrax exposure. General impression, we see poor respiratory distress. Immediately put our patient onto oxygen. And keep in mind also all of your pulse ox. Keep checking your pulse ox because we don't want that respiratory to get worse or anything. Treat them just as we normally would. Check pulse, heart rate. already in the hand. So have you have any other abnormalities or anything else that you?
No,
just in the hand.
Just hands, yes.
Okay, so he says he knows that he's gotten the mail, so he has been exposed. He probably just had a little cut. So we'll go ahead and he's a load and go respiratory distress patient. Load and go. Do a quick head to toe once we get him onto our stretcher. He's already decontaminated, so keep that in mind. We're still not 100% out of it, so with our lesions here, we can just go ahead and put some gauze on there. Don't mess with them too much, don't touch them too much, just leave them as it is. Always keep in mind how he's breathing, keep checking back on him. Get a set of vital signs, just continue to assess your patient as you normally would. Signs, allergies, medication, past medical history, last oral intake, do our sample, and once we're already on the road, make sure you call to the hospital. Call to the hospital. Let them know that we're going to be coming in with a possible anthrax exposure. He's inhaled. We don't even know if he's oropharyngeal also. We can ask also and get some more information. And our lesions, like we said, as much as we can. Care for them. We don't need to mess with them as much. Leave it as it is. Once we get to the hospital, they would have also a complete hazmat decontamination for the patient and for ourselves. And from there on, we're given the reports and give our patients over to the hospital. Now, each one of you already has a pop quiz set out, and go ahead and turn the page. You will have 10 minutes to go ahead